Good afternoon, everyone, and a very warm welcome to today's webinar. My name is Anushka Gupta, and I'm a research associate within the Health and Human Development team here at CSEP. Thank you for joining us and for taking the time to be part of this discussion. On behalf of the Center for Social and Economic Progress, I'm delighted to welcome you to this seminar on our upcoming working paper titled Drivers of Primary Healthcare and Elementary Education Initiatives in Rajasthan 2014 to 2024 by Dr. Priyadarshini Singh, Fellow at CSEP. Today's discussion focuses on understanding how and why state-level initiatives in urban health and education emerged in Rajasthan in the previous decade, what problems they seek to address on the ground, and what this means for improving public service delivery. This paper is part of a larger three-state study covering Karnataka, Rajasthan, and Orissa, and today we will focus specifically on the case of Rajasthan. We're joined by an outstanding panel of discussants who bring deep and complementary perspectives from administration, academia, and public health practice. Let me briefly introduce our panelists. First, we have Dr. C.K. Mathew, visiting faculty at Azim Premji University and former Chief Secretary of Rajasthan. Over a long administrative career, he has held several senior leadership roles across key departments, including education and finance, and brings invaluable insights into how policy is initiated and implemented within the state. Thank you for joining us, Dr. Mathew. Second, we have Professor Shobhita Rajagopal, former professor at the Institute of Development Studies, Jaipur. She has worked for over 3 decades on issues of gender, education, health, and social justice, with extensive engagement in Rajasthan. Her work bridges research, policy, and grassroots advocacy. Third, we have Dr. Pavitra Mohan, community health physician and co-founder of Basic Healthcare Services, a non-for-profit in providing primary healthcare in Rajasthan. He has also worked with UNICEF India on large-scale maternal and child health programs and brings strong field-based perspectives on health systems. Finally, today's presenter, Dr. Priyadarshini Singh, is a fellow with the Health and Human Development Program at CSEP. Her research focuses on the intersection between politics and social welfare, including health and education. At CSEP, she's leading the work on the political economy of state-level policy making and other work on geopolitics and health. Priyadarshini was a member of the Karnataka State Education Policy Commission. In today's presentation, Priyadarshini will walk us through the key findings from this working paper, highlighting what has driven recent initiatives in urban primary healthcare and elementary education, whether these initiatives align or fail to align with ground realities, and what this implies for future policy design. After the presentation, we will hear reflections from our panelists, followed by a Q&A with participants, so please feel free to post your questions in the chat. With that, I'm delighted to hand over to Priyadarshini for the presentation. Priyadarshini, over to you.
Thank you very much, Anushka. States are at the heart of social welfare provision, and their prioritization to health and education can rapidly improve outcomes. While national level initiatives get significant attention, whether it is the National Education Policy, PMJ, the states actually run the foundation on which these initiatives are implemented. But when we think of policy, states come in focus only when they make a distinctive high visibility program, free bus rides or mohalla clinics or Yashaswini insurance program, which gives the impression that state policy making apparatus functions as a unicorn. Incidental, sporadic efforts which spring into action to reform and fix, and in rest of the time, all that the states are doing is implementing. But states have policy ideating and policy initiating capacities that constantly produce new initiatives. So in this study, we aim to understand the policy-making pathways from which new state-level initiatives emerge. Rajasthan is a particularly important state for this examination. Rajasthan has a history of progressive social welfare movements, which have resulted in some of the most prominent national-level legislations, right to information, MG and REGA, to name a few, and several important policy ideas in health and education have come from programs that were initially implemented in Rajasthan, Shiksha Karmi, Lok Jumbish, free medicines, and were then later adopted by other states. And as I will later present today, in recent years, Rajasthan has made notable improvements in health and education outcomes as well. So we hope that this research work is the start of many conversations on state-level policy-making capacities. We also hope that policy attention is given to government provision for elementary education and primary health in urban areas. The 16th Finance Commission has provided notable financial resources to urban local bodies for rapid urbanization, and we hope that this project highlights that high quality human capital is essential for urbanization, and for this we need high impact government health and education systems. Okay, I'm just right. So as Anushka also highlighted to us, the broad question that this project seeks to understand is why and when a state, and in the context of today's presentation, Rajasthan undertook new initiatives for urban primary care and elementary education during 2014 and 2024. I'd like to draw your attention to two distinctive things about this study. This is a study of drivers of policy. It's not necessarily a study of drivers of what will achieve certain sorts of health and education outcomes, drivers of specifically successful reform-oriented initiatives. What we did was, over a 10-year period, we mapped all the key state-initiated, state-ideated, state-funded initiatives, whether they were reforming, whether they were trying to achieve certain outcomes or not, and tried to trace where did these initiatives come from. This is essentially a qualitative study. We use two tools. One is a policy document review, which is we reviewed key government documents, economic surveys, departmental reports, CAG reports, the entire sort of policy document infrastructure that the state creates over a 10-year period. The paper actually in its methods lists down the various categories of documents that we reviewed, and key informant interviews across 11 categories of stakeholders that inform the policy space in this area. We did the study at 3 levels: state, district, and facilities. And by facilities, I mean urban primary care centers and urban elementary schools. And we covered 2 urban constituencies, one in South Rajasthan and one in Central Rajasthan. Okay, so a quick snapshot of the state of health and education in Rajasthan. Is there a need for new initiatives? Actually, there is. There have been improvements, but these exist alongside shortages in access and outcomes. So urban primary care, there is a 32% shortage of facilities, according to latest data. If we look at staff, there have been prominent reductions in staff vacancies over this decade, in certain categories more than 15%, but around 50% shortages remain in multiple categories of staff at urban primary care centers. Again, outcomes have improved. Rajasthan has sort of pulled itself out of the very poor state of MMR, for example, 186 in 2015, 2017, up to 86 now, but the outcomes are hovering somewhere around national averages. In urban elementary education, technically there is no shortage of schools, but how many effective schools are available which can be taken up by urban residents? That sort of data is very fuzzy, and one indicator of that is the very high privatization in elementary schooling in urban areas. We did the number crunching for 2 areas, Ajmer and Udaipur. This is over 70% uptake of enrollment in private schools in class 1. When we come to outcomes, Rajasthan is a top performing state in NAS 2021. NAS is the only survey that covers urban learning levels. But the absolute numbers, I mean, all states are not performing well. So it's doing better than other states, but in its absolute terms, the learning outcomes need to be improved a lot. ASAR, which actually is a rural survey, not directly relevant to our work, but still we'd like to mention, the scores have improved, but marginally from 2014 to 2024. So clearly, there are challenges in outcomes, in access. There is a need for new initiatives. So what's happening in the world of initiatives? So when I set out to understand initiatives and policymaking, I realized that the policymaking is an ecosystem, and I use the term policy universe to sort of see how these various components are interrelated. So there are budgets and expenditures, there are initiatives, and then there are routine governance activities. So starting off with budgets and expenditures, Rajasthan allocates higher than the average of budget allocations done by other states, both in health and education. But when you look at expenditure levels have actually been declining over the last 10-year period. And particularly post-COVID, this decline in education is quite noteworthy and stark. When we come to the initiatives and governance activities, the story is a little bit more complicated. Education has overall lot more initiatives, but there is no defined focus on urban areas. Yeah. And within education, elementary education focused initiatives are also few. There are only three: free schools, free uniforms, and state initiative for quality education, which covers classes 1 to 8th. We also have initiatives that impact elementary classes. So these actually focus on the entirety of schooling years. Elementary classes are nested in it. And there are 4 such initiatives. Broadly, they are of 2 types: model schools, so other schools and Mahatma Gandhi English medium schools, and data portals. So you have Shala Darpan and Gyan Sankalp, which is a portal for mobilizing philanthropic and CSR donations. And in addition to this, there have been routine governance sort of activities. Recruitments have happened, but there are 25,000 elementary teacher shortages in the state as per the latest available data that we could access. In health, overall initiatives are slightly lesser, but they have a defined urban focus. Right now, there is one urban focused initiative for primary care, which is Janta Clinics. Janta Clinics have been renamed as UAM. Earlier, there was another initiative, which was Public-Private Partnership for UPHC staffing. This initiative has been discontinued. But in addition to this, Rajasthan also has 2 initiatives, which we call as primary care impacting initiatives: free tests and medicines. These are not focused on primary care institutions, but they've had a very distinctive impact on the value of a UPHC in its catchment area and the local community. In addition to this, in urban primary care, governance activities have included hiring across 6 categories of PHC staff and very prominent infrastructural upgrades. So there is a story of budgets and expenditures, there is a story of initiatives. But overall, what does this tell us? What are the initiatives trying to solve? In the process of trying to unpack what are the drivers of initiatives, we need to understand what kind of problems are being prioritized and what solutions are being given. So in the long list of things that have happened in education, it appears that lots of very complex problems are getting solved. There is real-time online data collection, education-related expenses, responding to demands of English medium of instruction, modern schools, streamlining CSR funds, improving learning outcomes, whereas in contrast, health appears to be really limited. All that you're doing is enhancing the network of primary care centers by providing Janta clinics, which are really extension clinics to existing UPHCs, improving staff availability, which is other way of saying improving access, and you're reducing out-of-pocket expenditure. So one would think that perhaps education has more of the policy-making attention than health. But we argue that there is a split in the policy universe between health and education. In health, initiatives are fewer, but they are somewhat system strengthening. There is a sense that budgets are being spent at the ground level. The kind of problems that have been identified at the state level and the solutions that are being proposed are somewhat aligned in a manner that enhances uptake and the value of the urban primary care center to the local population. So initiatives are not undercutting each other necessarily. In education, there are lots of initiatives, but at the ground level, there is a low sense of spending. And the kind of problems that are being prioritized at the state level and the solutions that are being provided are not perhaps the most critical ones that need to be addressed to improve the uptake of government schools in urban areas. So what we see in the case of health and education for urban areas is there are different shades of policy making. And I categorize them in 3 shades. There's policy action, policy focus, and policy prioritization. Primary health and elementary education are not necessarily government priorities for which you need budgets, expenditures, problem prioritization, solution provision, all of these aligned with what is happening to the challenges of ground level facilities and the needs of the residents to be going in somewhat a similar direction. Health still has policy focus. Policy activities are making primary care centers somewhat accessible, even though the initiatives are disjointed and being undertaken in a staggered manner. Education has policy action, policy activities. Lots of policy activities are not necessarily making the urban elementary schooling process accessible to a wide cross section of the residents and the population. What is happening on the ground? In the case of urban areas, the public school is missing. There are land and location challenges. Schools run in old rented buildings. Many of these buildings have court stay orders, so maintenance can't be done. School locations are at times moved to areas where the community can't access them. Basic resources are inadequate: chairs, tables, blackboards, playgrounds, textbooks. And while we hear a lot about teacher shortages, which is prominent, there are other kinds of shortages. Peons, the basic people who enable a school and a teacher to deliver the key services it is meant to provide, are running I have massive deficits. And most importantly, there is a certain kind of a negative signaling that has gone on to the community level. So when you ask school principals to raise money to run the school, the sense that people get is that the government is not running the school, it's running on charity, which then has implications for the legitimacy and identity of the urban public school. Enrollments are low and falling, but that doesn't mean that the demand for public education is absent. The value of a well-functioning government school can be seen in high volume of admissions that well-functioning government schools receive. But often these schools are not able to sustain their activities. The urban PHC, on the other hand, is a rising public facility. It's used by the poor and also some segments of the non-poor. There are new buildings, adequate spaces, upgraded infrastructure, medical officer who's the linchpin of an urban PHC. There are no shortages there. There are regular recruitment drives. Where there are shortages in frontline staff like ASHAs and ANMs, temporary hiring is done. So overall, this gives the sense that the facility is owned by the government. There is a vision, there is an alignment between what's happening on the ground and what the state level priorities are in some ways reflecting. So we have these two different policy universes of health and education. But when we look at the drivers, actually, the drivers are broadly within the same set of actors and pathways. The drivers are centralized. They consist of a limited set of actors, and it is path dependent on a certain kind of orientation. So policy is driven by a coalition of senior bureaucrats and senior most political leaders. And these actors are acting under immense distinctive professional pressure. So interested senior bureaucracy has very little time as a health and education secretary, and within that limited period they have to make a distinctive mark of how they address the health and education challenges during their tenure. Oftentimes this tenure is a little over a year. They also have to respond to the political vision set by the senior most political leaders and act within the capacities available of their departmental staff. On the other hand, senior political leaders, the chief minister and one or two people within that cohort, it has to select initiatives that perform two roles. One is that of branding. During non-election period, the initiatives have to enable the leader to appear as a good neta, and being able to provide social welfare, the new Janta clinic, moving the building of a school to a renovated, newer looking facility. It creates that idea of a social welfare provider, which is very important when elections are not happening. And during elections, they need initiatives that provide them visibility, which can be tagged directly to them during their tenure in power. In addition to these actors, many of these initiatives are actually coming from a central government push. And I use the word push deliberately here because the states do choose which ones they want to implement and what ideas they want to choose within that funding or policy idea that has been given to them. Broadly, in the case of Rajasthan, there is a certain historical policy and political priority to health, which got further legitimized in COVID-19. In the case of education, admissions surged. Government schools were being used by a far wider section of people, but the schools themselves were not able to prove themselves enough for the admission increase to sustain itself, and enrollments fell down. So on the one hand, there was one kind of public system, which is the health system, which was able to prove itself. On the other hand, the education system was not able to create a similar kind of legitimacy. During this decade, for urban primary care and elementary education, the impact of social movements has been limited. Similarly, internal bureaucratic feedback or election-focused mobilization people voting because a certain leader or a particular political regime is necessarily going to deliver them better quality of health and education has not really happened. So to go back to the question that I think Anushka started the session with, and what I raised is why and when did Rajasthan undertake new initiatives in primary health and elementary education in the last decade? We argue that when bureaucrats and political leaders have wanted it as part of their professional goals, the priority, focus, and drivers for health and education in some ways are a part of serendipity. A lot of things happen together at the right time. But where we are right now is a place where there is a case of the urban primary care center that can emerge into a public facility and can become the standard that a lot of other social welfare goods can aspire to. Is there anything you can do to change the drivers? We recommend three things. First is there is a need for a defined policy agenda for urban areas. And we suggest that a government appointed commission consisting of sector leaders and experts should be a part of this commission. The second is the need to enhance the legitimacy and legitimacy of UPHCs and elementary schools beyond the urban poor. So you need to advertise UPHCs and their services, emphasize audit quality and performance, highlight the cost savings, and for schools, remove the fundraising requirement for school principals. Use local media to publicize a phase-wise school strengthening action plan, and make sure that the state machinery is the key implementation pathway. The state has to appear as owning these facilities and as representing the needs, desires, and also ambitions of the people. I mean, they have to go beyond being the option of the last resort for the poorest of the poor to becoming aspirational facilities that people access to improve their status in life. And lastly, we recommend that we need to create profiles of assembly and parliamentary constituencies with data on health and education facilities and outcomes to create some kind of linkage between political leadership and what's happening in these two sectors. And I'd like to end at that, and I look forward to a productive discussion and to the feedback of our panelists. Thank you very much.
Thank you so much, Priyadarshini, for this very interesting presentation. Priyadarshini has raised a lot of very interesting findings in the course of this presentation, which I'm sure we will delve deeper into in our discussant's remarks. But without further delay, I'd actually like to invite Dr. C.K. Mathew to share his reflections. Dr. Mathew brings a unique perspective as the former Chief Secretary of Rajasthan with deep experience in how state-level policy is prioritized and implemented. And we're especially keen to hear his thoughts on how urban health and education have been positioned within state policy priorities and what can be done to strengthen the pathways, actors, and institutional channels through which better policy initiatives can emerge. So Dr. Mathew, over to you.
Thank you for inviting me here. Thanks to Dr. Priyadarshini and her colleagues. I have gone through the pages of the report in the last few days, and you have brought out a very comprehensive report. You have mentioned that this health sector has brought about some changes and some reforms, but not so in the education sector. And you've also pointed out that a bias towards rural vis-a-vis urban. So while I'm commenting on that report of yours, I'm probably suggesting a few more points or inputs that you can add in. I did go through the report, not so much in detail, but I wanted to know whether you have mentioned the SDGs, Sustainable Development Goals, which, as you know, Goal 3 and Goal 4 specifically deal with health and education. And I think the Indian government has brought out 2025 report of the progress of SDGs in our country. So it would be good to plug in some of these inputs so that when you are throwing it open to a wider audience, maybe even internationally, that will give a broader picture of how the situation is. Secondly, I'm not sure if you have brought in the 16th Finance Commission recommendations. Have you? No.
No.
So I find, in fact, I'll go ahead into that. As I go along, I'll mention that. Also a reference to the 73rd and 74th constitutional amendments, because these subjects have been transferred, have been delineated, devolved into the local bodies, urban and rural. So it will be good. And Rajasthan has taken certain steps to do that.
Yeah.
Not so much in urban areas, but more in rural areas. So I think you should put in something of these two amendments. And finally, perhaps you have mentioned it, the health missions, national health missions, have you mentioned urban and rural?
Yeah.
You have, okay. So I'll expand on some of these points as we go ahead.
Yeah.
So the reasons for this bias towards rural area is historical. It's not nothing new. It's been going on ever since we were independent. We began as an impoverished country. Large percentage of the population was in rural areas. Therefore, the focus was on the rural side and not so much on the urban side. But the fact is that today, the urban constituency is not defined clearly. There is no single voice. As in a rural area, you will find a particular brand or a particular voice coming out, expressing their demands. We want a school, we want a hospital, we want a power unit, we want fair price shops. There is a clear voice which comes out. But the urban population is diverse. There's a lot of migrants coming in. They are temporary population. They go back. People living in the slums. So somehow I think that the voice is not clear. It is scattered. That is one of the reasons. But one very, very important point which tilts the balance in favor of the rural side of the economy is the political structures that you find across, not only for Rajasthan, across the whole country. As you know, there are four political hierarchies in every district, in every state. One, you have the MP structure, Member of Parliament structure, and they have their own constituencies and they have their own interests. They get direct funding from Government of India. So that is one political structure. MPs of Rajya Sabha and Lok Sabha. Then you have the second structure with the MLAs. Across the state, Rajasthan has some 200 MLAs. So they form a special kind of constituency, which is largely rural based. And thirdly, you have entirely rural based PRI, elected representatives who are Sarpanch and Ward Panch and block president and district president. And finally, you have the elected representatives of the municipal corporations, municipalities. So now if you put these four structures and try to think about them, you will find that 1, 2, and 3 are very closely aligned. The municipal elected representatives stand a little apart. Maybe because their area, their jurisdiction is limited, and apparently they don't have the kind of voice that the other three have. So that itself brings a bias against the rural, against the urban areas. Their voice is not coming out clearly, and because they are in urban centers, their voice is drowned out by so many other considerations. Especially if you are in the headquarters, the voice of the municipal commissioner is or the municipal mayor is muted. It's not as much as it is. So I think one of the reasons why this bias is there is because the urban identity is unable to express itself clearly. So having said that, I now want to come to the 73rd, 74th constitutional issue. Although these two amendments took place, the evolution has been asymmetrical. The rural side has grown faster. And in fact, there is hardly any devolution to the urban side. If you look at the subjects that have been transferred to the PRIs and the ULBs, you know that I think it is Schedule 11, which says that towards the rural side, education including primary and secondary. This is item number 17. Item number 17 amongst the list of 29 items clearly says education including primary and secondary. These have been transferred to the rural side, to the PRIs.
Yeah.
But the corresponding schedule for urban side does not mention it. There is no mention of education being transferred to urban local bodies. There is no mention of health being transferred to urban local bodies. So in the very scheme of things, constitutional structure itself, health and education have not been deliberately transferred to the ULBs, whereas in the urban side, whereas in the rural side, both these items have been squarely placed in the basket of the PRIs. So that has to be kept in mind. Maybe that's one of the reasons why there is less importance for these two subjects in the urban areas. Even if you look at NHM, National Health Mission,
Yeah.
you look at the two streams and the ratio of funding.
Mhm.
Almost 90% of the funding is going to the rural areas. I've got this figure here. 30,000 crores is going to rural area, and only 1,500 crores is going to the urban side. So look at the vast difference, vast gap between rural funding and urban funding. And finally, as regards the 16th Finance Commission, one disservice has been done this time,
Mhm.
and that is that there is no sector-specific grant. Earlier, they used to allocate health, education, the commission itself used to allocate. But now there is no sector-specific allotment of funding. It is just a kind of a block grant. Now, what a block grant does is it gives great discretion to the state where it should be spent. Whereas if it is specific, the state has to spend in education or health or whatever area that the Finance Commission recommends. So I think these are some of the 3 or 4 areas where a natural inbuilt
Yeah.
structural bias is
Yeah.
there towards rural and away from the urban side. And if this is brought out clearly in your report, I think it will probably mean a little bit more weight for what you're trying to say.
Definitely.
So you have mentioned about urban schools.
Mhm.
Now, my understanding is that there is no shortage of staff in urban schools because most teachers want to come to urban areas, urban centers. So
Mhm.
they find out all means and ways to do that. In fact, you will find their posting in a rural school, but they're asked to depute or be on deputation in an urban school because the teacher's husband, wife, family must be working there. They try to come to the urban areas. But because of these earlier biases we talked about, funding is not there, the facilities are not good, the classroom is not looking good. So you have higher staff and lower facilities. I think that we must keep in mind. I remember a school very close to Gandhinagar where we used to stay, large building, full of teachers, but students and their facilities are hardly there, so that kind of a contradiction has taken place. So now if you ask me for my recommendations as to what should be done, I think the state can insist that whatever funding is given under the Finance Commission, the state has to take a decision. All right, 10% of this funding will go to schools or 15% will go to uh, health sector. So that is a decision that the state can take on its own, even though Finance Commission has not made any specific grant. If there is sufficient political pressure brought to bear and the MLAs of the urban areas agree, they can insist that you have to spend a certain amount on health or education. Second is, I'm not sure if the urban poor have any specific ID cards. Do they have in Rajasthan? I'm not sure. So there was a move that was taken long ago that while we have a clear list of the urban poor who are beneficiaries under various schemes, a list of beneficiaries in the rural area who are beneficiaries under various programs, a similar list does not exist for the urban poor. And an idea was given that there should be a unique number, photograph, and they will be eligible for all kinds of benefits. So if you can create a database which will look at the urban poor and identify them clearly as a special database. It's a big task. It's difficult to actually achieve it, but I think that would focus our attention on the poor and what kind of benefits should be given to them. Third suggestion I'm making is capacity building. Now, there is a lot of training at the All India service level. IS officers and senior officers, they have a regular schedule of training. Every 3 years, 4 years, they go for training programs. But the actual implementers, which are state service officers are the ones who actually go to the field and comply with the orders given by senior officers. Their training program is not ordered or structured at all. So after they get into service, yes, it may happen once, twice in a career, but a really focused training program for competency building, skill development, understanding issues periodically, maybe every 5 or 6 years, is to be introduced into the pattern of state service officers so that they gain knowledge about it. And I had one more radical thought. In the All India service, there is not much of career planning. When you can go from one post in, say, urban development, and suddenly you'll be posted into health, and from there you'll be in finance, and then you'll go to irrigation. So there is no planning of a career. And it is possible, if the government of India wants to do it, to divide this about 35 years of experience that a government servant has into clear areas. For example, the first 10 years, an officer spends in the field. He's either a subdivisional officer or a district collector. He understands about grassroots level functioning. Maybe the next 10 years could be in a particular sector, such as education or health or power or finance or whatever it is. And in the last 10 years, he could specialize in those areas that he has a personal interest in. So you are allowing his personality to grow, you are allowing his skills to be honed, and then he becomes really an expert on what area he's working in. So can we think of, even if not done by Government of India in the state itself, can we think of a planning of a career of an officer in such a manner that there is consistency in how he evolves and grows? And I think we very rightly mentioned it, that the leadership comes from the political leader and the bureaucratic leader. If their vision coincides, then miracles happen. But it is very rare to get that kind of a combination. Happens because of various reasons, including ego. Sometimes ministers are a little stern, little strict, and they have a different way of talking and the way they communicate, while officers may have their own, style of doing things. I was for 2 years in the education department. I had a fairly good relationship with my minister, and think we were able to push things through because we see in the same way. So how do we get the political leadership also to understand these issues and work very closely with the bureaucrats? That itself may require a orientation program, a kind of periodic revival of each other's views, understanding each other's views and taking it forward. Very difficult, especially when politicians keep changing, portfolios change, you are transferred from one job to another, so that continuity is not there. One should hope for at least 3 to 4 years in one particular department. That rarely happens. And one thing that I think you could include is the actual voice of the people. Where do we get the people's participation? Somewhere in our reform program, there should be a methodology for getting the voice of the people to feed into what you are going to do. So I know there are panchayat samitis, there are blocks, there are wards, but their voice is not converted into inputs for policy making. Very difficult again. We have very powerful NGOs, as you mentioned. I remember long association with Mrs. Aruna Roy, for example, who was right on the field, and she had good relations with all the officers, with the political leaders. She was able to convey what the people feel. She got RTI through, the right to information partly moved by her. Narega was moved by her. So she had that clout and that voice. So if you get good NGOs who are able to bring the voice of the people to the secretariat, to the secretary, to the political leaders, so people's participation has to be a very, very important part of your strategy as we go ahead in this. I think that's about all I wanted to say. I wish you all the best. I hope this report comes out and things start moving, not only here, but in other states as well. Thank you and well done.
Thank you very much, Dr. Mathew, really.
Thank you. Thank you so much, Dr. Mathew, for really sort of delineating the structural and historical focus on rural areas, and also very important recommendations for bureaucratic reform, state autonomy, over 16 Finance Commission funding, and of course your last point about channels for citizen voice to feed into inputs for policymaking, really very important. I would also actually encourage anyone who has questions to sort of put it into the chat box, and please feel free to direct your questions to any of the discussants, to Priyadarshini here as well. Next, I wanted to invite Professor Shobhita Rajagopal to share her perspectives. Professor Rajagopal has worked extensively on gender, education, and social inequalities in Rajasthan, and was especially interested in her reflections on the key challenges affecting urban elementary education and urban children, and how these really differ from the realities and policy concerns in rural areas. With that, over to you, Professor Rajagopal. Looking forward to hearing from you.
Thank you. Thank you, Anushka, and thank you, Priyadarshini. It's good to be a part of this discussion along with Mr. Mathew and Pavitra Mohan. I think all of us have, in our different phases of work life, been very involved in different sectors in Rajasthan. Um, I was reading the report that you had shared, and also now the presentation with a fair amount of interest. Having been in IDS for about a long period of time, I was just recollecting that when you talk about the kind of challenges that came out when we looked at urban education, um, I just trying to ask myself, what has changed? Where is it that things have changed? Yes, we see more number of children coming to school. So in terms of access, yes, we may say that we have moved, but in terms of a number of challenges, I think it's the same set of things that are coming back to us again and again. We are looking at a decade 2014 to say 24. I know you have mentioned that there are a kind of 11 initiatives, of which I feel that a couple of them, if you take free textbooks or kind of uniforms, I mean, that is something that has been happening maybe for the last two decades or so. So I don't see that as kind of a major initiative that has come along, right? There was a lot of focus in again we all know that somewhere urban schooling has not been so much center stage vis-a-vis kind of rural education. Yes, we know that. And also some of the other initiatives that you have also mapped in terms of the other schools and maybe the Shala Darpan, where I do remember that we were looking at some real time data. But the question which you've also raised in your report is saying that they, does that data really get used for policy making? And somewhere that was the starting point, that if we have data of schools and we are tracking children and we are tracking the processes that are happening at the school level, then we know what the challenges are, we know what the gaps are, but still we are somewhere missing the bus. And still today uh, we are talking here about why urban schooling is not a focus. um, Recently a small group based out of Jaipur is working in four urban schools of Jaipur city. Okay, two of the schools are in uh, the walled city of Jaipur, and two are on the periphery, like and all catering. I mean, and we all know that the children who come there, and more specifically girls who come there, are from the more disadvantaged. So on all of that you have put out in your report, I'm just trying to understand what are the gender implications, if we have a situation which is like that. Today in a local newspaper, it has there is a report which says that uh, enrollments have really come down in government schools, and both in primary and upper primary. It's clearly, and we all understand this, that the number of girls who are enrolled in government schools, both at the primary level and at the upper primary level, is much more than boys. So what happens if a school where I send my child to is not functioning? And again, it's again, we are talking about the same set of issues: infrastructure, teacher appointment, or teacher deficit. And I'm told that in one of the schools where this group is working, out of 8, it was an upper primary school, and out of 8 teachers, 6 of them were given the task of updating the SIR and other set of issues. So the principal was really in a bind. She said, what am I supposed to do with two teachers and a whole lot of children coming, and actually nothing much happening in the school? So like I said, if we start looking at what is it, even at the policy making level, why is it that we are not able to address some of these issues? And urban schools, mind you, even in Jaipur city, which is capital, and everything is under people's noses, we know that in the walled city there is such a problem of space, such a problem of everything, but there are children. So again, we are somewhere, this kind of misalignment and a misfit is something that we need to consciously address. And I also believe that somewhere there is this kind of an attitude that, okay, some of these children are from the most disadvantaged groups, तो इनको कैसे भी आप पढ़ा लो, ठीक है, इनको करो नहीं करो it, but there does exist something like that. And just now Mr. Mathew made this point about, do we have unique identities and for the urban poor? But at least I know for a fact that some of the schools which are located in the resource poor areas and the bastis, the girls and boys too are not getting admission in the school because they don't have the relevant documents. They said Aadhaar law, they say you get us this, you get us that, but they are not able to produce some of these. So how are we going to address some of these issues? So this particular group decided to do a survey to see how many of and the parents don't have time because they have major livelihood struggles, and for them that is more important कि हमने बच्चे को भेज दिया पर वो कह रहे हैं हमारे को we need a piece of document. So and again I'm kind of reiterating that some of these issues are not issues that have come up like today. We have been dealing with it for a long time. And so as far as I can see, I think we need to really look at issues of monitoring, and some kind of a feedback system. Even if we as people who are not within the system, who are working maybe in some of the schools, we want to suggest a few things, it's not even taken in the right spirit, because they said ki ha aap to bahar ke log hain, aap aa jate hain. So where is the space? So even if I want to say that these are the 10 challenges that we have, and we all know what the challenges are we is there space to kind of listen very carefully into what needs to be done, and what if somebody from the outside is giving a suggestion, is there a willingness to take those sets of suggestions? The other, I feel, is there is no platform for dialogue. There is no platform for dialogue, and there is no dialogue with the parents, especially if you're looking at resource poor areas where there are government schools, there are maybe a motley number of children who are coming into, but there is no dialogue with the parents, because either you cannot kind of adjust to their timings because they are struggling and they are but then who takes the initiative? Are we even asking the parent, what is it that you feel should be happening in the school? Where is that dialogue? There is no space for some of these things. So I think we need to kind of it's not one size fits all, because Mathew just mentioned the Gandhinagar school, which is very well appointed right in the middle of the city. But I can talk about another set of schools where you have children, but then there are other things which are missing. So what do we do? So who is there an audit? Is there a survey? And even if there is a survey, what happens to it, and how much of the things are pulled out for policy making. So I think some of these issues, and also as far as I can remember in my work kind of life, and I have barely seen any urban councillor coming to a government school and interacting. Maybe if they might come for some kind of a Republic Day, Independence Day, but there is no I mean, what I mean is there is no dialogue that is happening. So I think in the absence of dialogue, I think we are missing out on a huge set of maybe we can find answers if there is some dialogue which is happening at the community level. It's not just education administrators or maybe bureaucrats, but I mean, can we do that? Can we have some kind of a meaningful dialogue with parents, with even with teachers? Because see, there are many outliers where principals and teachers are really struggling to see that their school functions. So are we taking some of these into account? I think we need to kind of broaden the framework where we get other voices to come in and to say what is it that will work, and what is it that we need to just kind of put away because it's not working. And I guess in the current dispensation, I mean, I know this might get people slit off track, but there is no space for dialogue. Where is the space for dialogue? I don't know if it's in the health sector, it is there, but I feel that in the education sector, there's very little space for dialogue, or for people wanting, kind of suggestions to take some of the issues that we are talking, to take them forward. I mean, we know all that. I mean, we can talk about monitoring, we can talk about feedback, but actually, it is about having a space where uh, people can say that this is what is going wrong, and maybe if we tweak some of these things, things can get better. I think I'll stop here and maybe come back later.
Thank you, Professor Rajagopal, for those very important remarks. I think your insights around the gendered pattern of enrollment in urban government schools sort of also ties back to Priyadarshini's earlier point on enhancing legitimacy of the public school and not making it a sort of option of the last resort option for the poorest of the poor. And very important recommendations as well. So I do see a few questions in the Q&A, and I again encourage anyone else who'd like to sort of ask a question to type it there, and we'll take it immediately after Dr. Mohan's intervention. So with that, I would like to invite our last speaker today, Dr. Pavitra Mohan, to share his reflections. Dr. Mohan brings a strong practitioner's perspective from working on primary healthcare delivery in Rajasthan, as well as broader experience with national health programs. So Dr. Mohan, over to you. Really excited to hear your thoughts.
Thank you, Anushka. And thanks to my previous speakers. There's, I think, much more exciting than I thought it would be. There are a lot of new ideas and thoughts from both Mr. Mathew and Shobhita. I mean, I'd like to begin with saying that it is, to me, the challenge is not, I mean, there are, of course, specific challenges that urban and rural face and needs to be addressed. But I think there is also a larger question that needs to be posed, which is public systems versus the role of public systems in delivery of education and health. How does the state view its responsibility of delivering education and health, or does it want to relinquish it to the private sector? I think that's one bigger question, and it relates to both rural as well as urban. In urban, there is a greater chance because there is higher paying capacity and higher density, and therefore it is more lucrative for private players. While in rural areas, it is less lucrative for private players to set up health services. But that's one kind of a position I would like to pose. The second is that whether is about the healthcare as well as education of the marginalized versus others, whether they are in urban areas or in rural areas. The kind of people who are marginalized may be different in urban and rural areas, but there is this whole question, are we focusing enough on the healthcare and education of the marginalized versus those who are not socially or economically marginalized? Having said that, I would say that in Rajasthan, if we specifically look at health, broadly, I think there have been historically, uh, some of the very good kind of policy and as well as the services environment much better than many other states. I'll take a few examples of free drug scheme, right? I mean, it started in 2011, irrespective of the political, the dispensation, the scheme has continued and it makes drugs available at a primary healthcare much more than in many other states, except for a few states that have access, and that improves, utilization of public systems. Um, the budgetary allocation that Priyadarshini mentioned as proportion of total budget in health has been higher than most other states. I know of only 2, 3 other states which have still not sufficient, but it is much higher than in many other states. The infrastructure, I mean, I've in my early days and now whenever I visit a state and look at its infrastructure, Rajasthan historically had, a primary health center at 20,000 population since many, many years. 2 ANMs allocated. I'm only talking of allocations for 2 ANMs in every subcenter in tribal areas and desert areas for 20 years, much before NHM came. So some of those have been historically been a focus on public systems per se, I would say. And since I'm more familiar with health, I know that that had been the case. There has also been a history of what Mr. Mathew referred to as interaction with civil society and inclusion of civil society in public schemes and services. Now, Right to Health Act, which I think probably needs mention here, is again something that Rajasthan was among the first one to have the Legislative Assembly having passed the Right to Health bill and made it an act. Again, rules have not been framed as yet. There is much lesser traction for it now, and that's one thing about Rajasthan. There are a lot of acceptance of new ideas, but performance on the ground often lags far behind. And that is a work culture issue which I think affects services and service delivery in Rajasthan. It's of course about policies and allocations, but it's also about how governance or lack of it, or how does that affect its actual implementation on the ground, despite having several of these things in place. Now, how does now coming to so just for once, going back to this rural versus urban, I would say that when you show the vacancies in urban areas vis-a-vis rural areas, you didn't show it vis-a-vis rural areas. So there are vacancies everywhere, and there are huge vacancies in tribal areas, much higher than in the urban in urban areas. So I think when we look at some of these parameters, we need to look at both. In general, in urban areas, vacancies are much lower and sometimes at the cost of rural areas, because people do get their transfers from urban areas, from rural areas to urban areas, and therefore there would be often a much higher number of people, many a times lopsided, right? I mean, there will be an urban PHC where there will be 4 doctors, but then this is often at the cost of a rural PHC from which the person has got transferred, or sometimes even without a transfer. There are all kinds of mechanisms of deputations, etc., that affect. So in general, I think inequities in healthcare persist across rural and urban areas in Rajasthan hugely. Averages overall, as you showed with respect to maternal mortality and infant mortality, have improved over the years, but there are huge inequities. And that is where, again, the focus needs to be, that where are these inequities and how can we, minimize and improve there. There are, of course, a few things which are unique to urban health as compared to rural health. One of the, I think, most significant one being the presence of migrants who do not belong to the cities but have come for work. Rajasthan, of course, is more predominantly a sending state, right? I mean, many people move out rather than come in, but that is changing. There are increasingly pockets of industrialization where a lot of people are moving in. Jaipur has lakhs of people coming from all over to work, both from within the state but also from outside the state, and that is what makes access to healthcare very easy to deny, right? And even in the Right to Health Act, while the rules are still not framed, there was a strong pushback on including migrants as part of the right to health. So they remain invisible, they remain unaccepted in the city which they are building. So that I think is one major area where, and with growing industrialization, this is only, the numbers are only going to grow. And if you look at, while you said that it is good to have a state focus, but in view of urbanization and high levels of in-migration for industrialization of small and big towns, uh, where do you consider? Do you consider it the responsibility of the state or of the center or of the sending state to provide healthcare? How do you see that? And who provides and who plans for that, right? Those large number of people who are absolutely invisible, they are not often included in the denominators for public services. I mean, vaccination, you are not even counted if you are living in a factory site or in a, inside the construction site or on the streets. The other, I think, problem which is related is the whole issue of community participation, involvement, engagement. In rural areas, it is still possible to do that more because people are at one place and there is a somewhat static, while in urban areas, long work hours and not belonging to that place doesn't bring any cohesion or cohesive structures that can be built on to. So that also makes it more difficult. And we have to have creative ways. But at the same time, we have a lot of examples from many places, especially those more industrialized states, but even more so from many other countries which have been much more urbanized much earlier, and how have they looked at community participation using different kind of platforms, etc. is another area. The third is a disease profile per se, right? I mean, so there is of course a difference in disease profile both among the infectious and non-infectious diseases because of the crowded living conditions, etc. There is a higher likelihood of many diseases like tuberculosis. Construction leads to a lot of dengue, and non-communicable diseases are much higher because of the kind of food people eat and the relative lack of movement. Um, the other thing that I think when we are talking of urban health, which gets missed, is the whole issue of occupational health. So a lot of these, both migrants as well as local workers in urban cities, work in extremely hazardous situations where there are absolutely very little provision of either prevention or management of disease to to destruction of lungs or of kidneys and whatever else that a lot of these occupations cause. I mean, for example, in South Rajasthan, there is a lot of industry which causes silicosis, right? Now, how does health sector respond to such a situation? Is it part of their and these are often located in small towns increasingly, right? Or on the periphery of the small towns. So, has urban health envisaged that it is their responsibility, or is it a labor department? How do they work together to ensure healthcare to this population? So those are some of the challenges that urban kind of health specifically has. So I would go beyond the whole issue of whether we have enough focus on one or other, but to say that how do we strengthen our public systems to respond to needs of the marginalized population, both in urban and rural areas. I think there is a need for, specifically a need for an urban health policy with a focus on migrants. If you look at the national health policy, there is not a mention of the word migrant at all. So while it does, of course, has a small section on the urban health and mentions it. The other thing also is that urban is important because it also provides healthcare to the rural population. I mean, not only the migrant population, but also from surrounding areas, etc. So the hospitals also perform a primary care function. So having strong urban health systems are important in any case, and therefore we need to have a specific policy with focus on migrants. There is also needs to be a much stronger now. I mean, as I said, historically there had been much greater interaction of civil society with the government. There are many platforms which are still, some of which are still there, but they increasingly there is much less interaction and space for dialogue. Shobhita was talking about the space for dialogue between communities and teachers and schools, and I'm also talking of the dialogues and space for interaction between civil society and the state much more. Overall, I think there is within the health system in general there is need for I mean, as I'm saying that the issues are emerging, right? COVID showed us was one part of it where we looked at an emerging disease which suddenly came, and climate change is another, and many change in epidemiology. And so only a strong, resilient and a more decentralized system can work well, where there is a strong work culture. I think a work culture is very central, and decentralized capacities where people could identify problems, respond to them, and have the capacity to do so, and they're mandated to do so, which is lacking in health systems in general. It is very centralized, very top down, with very limited autonomy and here at the ground. So I'll stop here and then we'll be happy to take some questions.
Thank you, Dr. Mathew.
Thank you so much, Dr. Mohan. I think really important point on highlighting the exclusion of key groups such as migrants in the urban policy-making imagination. Thank you so much to all our discussants, actually. And I see a couple of questions in the chat. I know we have around 10 minutes to go. So I'm going to actually maybe relay the first question that Prakshi Saha has asked about MPs and MP LAD funding to Dr. Mathew, if that's all right.
Yeah, I can see that question. MP LAD has been around for several years now, and you will find that the utilization of the funds is largely based on the personality of the MP. If MP is very active, very proactive, he runs around, finds what are the requirements of the people, it gets done. Within a year, all that funds are utilized. But simultaneously, you have other MPs who are not bothered, have their own interests. So, how to push each individual MP into utilizing the funds for his area depends largely on his constituents. It cannot be centrally directed. You can't have the Prime Minister saying everybody. Yeah, he says it. There are occasions where he encourages the MPs to utilize their funds. But ultimately, if the people of that member of parliament area push him, I know of some MLAs, MPs who focus on, let us say, education for a year. One whole year, all funds spent in education. Next year, it will be health. Third year, it could be maybe transport, whatever pressing area there is for being addressed. So I think, as we were saying, the voice of the people, voice of the constituents, shouting so loud that if he's allowed to, he's asked to do it. Again, we come back to the question of public participation and how to push MLAs, MPs into doing what they have to do. It has to be the voice of the people. That's what I feel.
I think a common a common argument being made by everyone is the need to sort of reflect views of citizens and basically diversify the stakeholders involved in the policymaking process. I'm going to just use my discretion in the Q&A to ask, maybe I'll just try to summarize Alok's question there. Maybe Dr. Mohan, if you'd like to take this question that Alok Singh has asked here about essentially he's making a case that the availability of services in urban area hasn't really led to utilization, and he's bringing in the complex governance structures and the fact that community-based care has been missing from the narrative. So how can we address this in urban areas?
So I think in urban areas, I would not entirely agree with the fact that improved access has not led to increased utilization. And when I say access, it is not only access, it's access of some quality services with basic tenets of availability of drugs and people and diagnostics, etc. For example, I think Mohalla clinics in Delhi in many cases had shown that if you are more closer to where people live, often the urban PHC, the way they have envisaged are same as for rural PHC, which is covering up X population or Y population. While it may be very kind of distant from where people live and the kind of work people do where time availability, etc. is limited. So I think if they're deep into the neighborhoods and are stocked with drugs and diagnostics, people do utilize. There is a huge need and people do shift. The other is, I think in urban areas, there is a growing incidence of chronic diseases. All of us know that, and non-communicable diseases are extremely high, while typically primary health services have been largely directed towards management of acute conditions, etc. And therefore, they are neither equipped with the wherewithal to manage long-standing chronic care. And that shift would also leads to increased utilization of services. So I think if people have access to relevant care close by, they would use it. There is, of course, the whole challenge of how do you involve communities in urban areas, which I alluded to, and which I think Alok also mentioned, that how do you involve communities. And I think there have to be more creative ways of doing that. And in urban areas, people have tried different ways, and we also find it extremely difficult to reach out to migrant families, for example. And there are, so I think first of all, need to ensure that we know where people who are invisible or vulnerable live in the catchment area, define the catchment areas better. In urban areas, often other problem is that the catchment is not very well defined, and within that, where most vulnerable people live is not very clear. So reaching out, mapping them, and proactively reaching out is critical. So
Thank you. Thank you, Dr. Mohan. Maybe we'll take one more question and then I'm going to hand it back to Priyadarshini. For Dr. Rajagopal, so we have a question again from Prakshi. Thank you, Prakshi, for being so active, actually. That, health and the gendered context is very important in health and education, as you pointed out. And Prakshi sort of asking how WASH, water sanitation and health, SRA, sexual reproductive health, impacts education, and how policymakers can take a more intersectional approach. So any thoughts on that?
No, I would agree that especially in the context of girls, there are, I mean, one example is menstrual health and other issues, which do impact their kind of regularity in schooling, and there has been enough around attention around it in the last few years. But like I said, I mean, there was this, at least in Rajasthan, and Pavitra can correct me, there was a lot of fanfare around having a menstrual health hygiene program, and talking about distribution of products in schools. And I think what we understand is across urban and kind of rural schools, but the entire distribution of that has been so kind of mismanaged, and you don't get products on time, and it's on. And we keep talking about basket of choices and other things which is not there. And even in terms of talking and having dialogue around SRHR at the school level, I think it is not percolated the way it should be. Recently, in this particular, I was talking about these 4 schools where this group is working. They had a session on menstrual health and hygiene, and they and later there was a call from the principal to say that I am told you talked about you kind of introduced some pornographic material in this school, and what was it that you talked about? So here we are, we still are kind of at this stage where even talking about menstrual health seems to be getting people very uncomfortable. It should be, it has to be part of your curriculum in the school, but as we all know, I think it is still an area which is not being talked about the way we want it to. So and policymakers, I mean, it was a policy about at least distribution of products, I know, menstrual health products, but like I said, I don't know who has monitored what has happened to that program and what is the kind of feedback that is being given. So we still are kind of struggling with some of these issues.
Thank you so much, Professor Rajagopal. Over to you, Priyadarshini, in case you want to reflect on any of the questions and, of course, all the comments that have come in.
Incredibly insightful conversation. I'd really like to thank all the panelists. Just a quick response to one of the questions that was directed to me in the Q&A, which is that if I observed any striking differences or similarities across the two political regimes in the state. So the fundamental drivers or the policy pathways are largely the same, right? So it's the actors, it's a very limited set of actors that are operating at the state level. It's senior most bureaucrats, senior most political leaders. There is a certain kind of senior bureaucracy, senior political relationship, that dynamics that shapes what sorts of problems get prioritized and what solutions are developed. As I think Dr. Mathew also reflected, that those unicorn initiatives happen once in a while because the institutional ownership of health and education agenda as a whole, that would sort of repeatedly take monitoring and evaluation reports into account, course correct, self correct, reflect, collate, and the agenda making function that has to happen by getting all stakeholders in the room, that doesn't seem to be happening. And irrespective of which regime is in power, certain regimes may prioritize certain problems, but like the larger driver ecosystem remains the same. Couple of questions and thoughts that came in the course of the discussion. Of course, I'm very grateful for all the recommendations and suggestions for improving the report that have been shared by the panelists. Some of the things, in terms of teacher shortages and, the overcrowding of teachers in urban schools, that is a phenomenon. But what we observed during fieldwork was that there are some schools that have a lot of teachers and very few students, but there are others where there are chronic shortages, and the shortages happen both because of lopsided deputation, but also because teachers go off on non-teaching duties, schools become exam centers. There are all kinds of things that happen which give the impression within the community that kuch bhi chalta hai, as I sort of like Dr. Rajagopal pointed out. Similarly, in the case of urban primary care centers, there were those centers that did have disproportionate number of staff, but then there were others that were facing shortages. And what was our distinctive takeaway during fieldwork of observing how these UPHCs were being accessed, used, and valued by both the poor and to a little limited extent also the non-poor in the catchment area, was the fact that even though the health needs of the catchment area of a UPHC was very complex, the people were accessing hospitals, they were accessing private care providers, they were accessing informal providers, but where the facility was functioning well, they were operating at capacity. So clearly the health needs are far wider than what can even be catered within the services and the staff available for well kitted out UPHC. So we actually took that as a very positive sign of belief in the public system when the public system performs. So we saw that as a sign that within urban areas, that worry that some of us had that the preference will always be to private option seem to be somewhat misplaced. If you provide something good, dependable, reliable, accessible, it is taken up. We'll definitely be reflecting on all the suggestions and comments that have come our way, and hope to engage with each of the panelists in other outputs that emerge from this work. And thank you very much. And thank you very much to the audience and participants who've stayed with us for over 15 minutes now. So thank you. And thank you to Anushka. Thank you very much.